Hello, everyone, and welcome to our webinar, How to Make the Most of Your System's Billing Rules. All lines have been muted. The webinar will last 30 minutes, and we will have dedicated time after the presentation for Q&A. If you have questions throughout, simply type them in the comments section, and we'll address during Q&A time. The webinar is being recorded and will be sent to each participant afterwards. Our speaker for today is Tracy Holt. Tracy is a member of the practice optimization team at iCare Leaders and has more than 20 years of experience in healthcare, working in management, reimbursement, billing, and coding sectors. We appreciate you taking time out of your busy schedule to join us today. At this time, I'll turn the webinar over to Tracy. Tracy?
Thank you, Teresa. Thank you, everyone, for joining today. I hope you're having a wonderful day. Today, we're going to talk about something that I really enjoy doing, and that's setting up billing rules within the system to help with the claims management and denials. So we will just go ahead and get started and jump right in. So just real quick, no part of this presentation may be reproduced or transmitted in any form or by any means without the express written permission of iCare Leaders. And on our agenda today, we're going to discuss Medicare local coverage determinations, commercial insurances, and then get into a few billing rules. Most of our practice management systems today do have a way to add billing rules within their system. Also, most of our clearinghouses, if you have the correct access, you will be able to create additional billing rules on the clearinghouse level. So obviously, whatever we're sending out from our practice management systems to our clearinghouses, there's just kind of that first level of defense. We're looking for, is the patient's gender listed? Are the dates of birth listed? Do we have a policy ID number? But there are other issues that could happen on the claim. Does a specific insurance company require a 50 modifier versus a right and left, or are there diagnosis code issues? So those are the type of things that we can definitely set up within the system. And some of the other items that you should be looking at is also the commercial payers. Are they specific enough that you would want to create a billing rule to that? Really, it's a matter of how detailed should you be. You don't want to make it so detailed that the staff has to go through several alerts or billing rules in order to get the claim processed or entered into the system, but you wanted to make it enough that the system will work for you instead of you working for your system. So let's talk a little bit about Medicare local coverage determinations. As we know, Medicare has MACs for different MACs have different Medicare LCDs. One MAC may have an LCD for fundus photography, whereas another one may not. So you really need to make sure that you look at your different policies within your local region. And if your state has a specific local coverage determination, then your state, if it is more stringent, will outweigh the national one. If the state does not have one and the national level one does, then you definitely want to be looking at that national level LCD to make sure that the claims are being processed correctly. One of the main ones, obviously, is fundus photography for ophthalmology, and they have their diagnosis code for medical necessity is roughly, last time I counted, around 30 pages long. So we want to make sure that our billing staff does not need to remember all of those diagnosis codes, but if we can put something in place that says, you know, make sure that you look for this local coverage determination or refer to your notes for, then that will help. On the flip side of that, if your Medicare requires a specific modifier for a CPT code, or if they want it filed in a specific way for, let's say, punctal plugs, instead of doing the right and left eye, they may want it as a 50 modifier. You can set up the system that will allow you to make sure that whenever you put in the 68761 CPT code, it will automatically apply that 50 modifier to the claim. So then the staff does not have to remember that as well. So whenever we talk about commercial insurances, there are a few payers that do have specific guidelines on specific requirements for filing. For example, I have a state-specific carrier requires the units for injections to be covered in milliliters instead of as 1 unit. So they want, instead of it being 1 in the units, they want it to be 0.05. And for 2, they want to be 0.10. Well, we all know with all of our insurances out there, there's so many of them, it's hard to keep these little details in our brains and at the hand of ourselves. So the best thing to do, instead of having cheat sheets all over our desk and everything, is to try and create this. So in your system, you could create a billing rule. Let's say it's Aetna, that anytime a patient has Aetna and they have an injection, then it is put in, the staff can go ahead and enter in 1, but then the system will automatically change that to the 0.05. And then with that, it makes it easier that the staff knows that that's going to happen. You're not going to receive rejections regarding that. Most of the rejections that we do see that are not just common rejections, such as policy inactive or something to that effect, are due to coding and the way that it was sent out, and requiring a modifier, not requiring a modifier, wanting something specific in box 19, requiring that you use a 50 modifier, or they want RTLT on a separate line. And then obviously our Aetna's, United Healthcare, Blue Cross Blue Shield, they have payer-specific policies for testing. So not only does Medicare have those, so does our major commercial carriers. And sometimes, it's hard to keep them straight because what Medicare allows, and Aetna may not allow. For example, E11.9 on fundus photography may go through with Aetna, but Medicare wants it more specific. So those little discrepancies can mean a lot whenever you come down to the timeliness of your claims, being able to work those rejections or denials, or even having the staff to be able to do that. The more efficient that we can make our billing staff, the more efficient the money will come in. We'll have less rejections and denials, which ultimately, that's our ultimate goal, is to have everything come in faster. So let's talk about the billing rules. The purpose is basically to help the billing staff. That way they don't have to remember everything that's going on. They don't have to remember all the nuances for all the different insurance companies. And your denials and rejections can obviously be reduced. On average, denied claims cost the practice money. And whenever you quantify that, it takes roughly 4 minutes to identify the denial and then route it to the appropriate staff member. So let's say you have a denial that may be for a modifier usage, and your system, your office is set up to where it goes back to a specified coder. Then the staff is going to have to document that, send that over to that staff member, wait for them to come back with the answer, and then refile that. So it could take 10 minutes of gathering the information, another 30 minutes for compiling and filling out an appeal letter, and the materials that are required with that, and then another 5 minutes to document all the steps taken within the PM system to actively appeal that claim, or calling the insurance company and trying to get them to just reprocess the claim so you don't have to send out another claim. So let's say that our billing staff member makes $12 per hour, and that's an additional 25% cost on top of that. So now she makes $12.25. So if we have 10 denials per week, that would be $122.50 for 1 week. But if you multiply that by 4 weeks in a month, you're talking $490. And then for the entire year, just on 10 denials, is $5,880 per year. And I am sure that there's a lot that we could do with that $5,000 within the practice. So that's why I like looking at the billing rules. I also like looking at clearinghouse billing rules as well, because I want to make sure that the edits that are there, that are already in place, that the insurance company set in place, are okay. But then I can really drill down into further saying that, for example, Medicare secondary claims. We know that not all Medicare secondary claims cross over by Medicare. So by saying that, we can go ahead and file the claim through our practice management system. And how many denials do we get back saying that it's a duplicate claim? I know that I've received several. So if you can create a billing rule within the clearinghouse where the claim will actually go out the door, but then not actually go to the insurance company for 30 days. If it's paid, then it will be set to go out. And if not, then it will stay within the clearinghouse and be paid and show as zero. So then you're not sending out additional work. You're not, if you send them paper, you're not sending out HCFA 1500s and making copies of the documentation that goes along with that. The staff is not having to do all of that extra work. What they would actually be working is actually true Medicare secondary claims that did not get processed to the insurance company. And the reason why I chose 30 days is because generally by the time that Medicare and we receive our remits from Medicare, the claim has already been submitted electronically to the secondary insurance company. So I don't want another claim to go out to them and then that claim gets denied as a duplicate, but then another claim come in as being paid. So I have a rule set up that within 30 days, if the claim does not state paid in my clearinghouse, then I get a report, I run a report, and then I know which ones that I can release. And I manually do that. But if you think about it, you know, most practices have a very high number of Medicare patients. And so you may be looking at 50 claims could easily go down to 5 claims. So by doing that, and just makes the staff not have to look at 50 claims, they're going to look at 5 and then go to their next task. So it's just making the staff more efficient. There are other billing rules within the system that you can set up in the clearinghouse, and you can get as detailed and on the granular level as you would like. I would caution that the more granular that you go, the more room for problems to occur. So I like to look at it as a overall global of what can I do on the front end to make sure that the claims go out correctly, and then work on the clearinghouse and say, okay, now I'm receiving these denials, but I can't fix that in my practice management system. Can I do something in the clearinghouse before it goes out? So just a couple of examples here is the one that I have up on the screen now is where for an EYLEA injection, they require NDC numbers. And if there's not a place to actually put that whenever you enter in the J codes, you can set up a billing rule that automatically puts the NDC number in. And then let's say this insurance company also wants a little blurb that says that it's an EYLEA injection at 0.05 ml. So that will automatically, whenever the staff enter in a J9035, that information will automatically be added to the claim. It's not something that they would have to remember. And then that way, you don't have to worry about the claim being denied. You can also make it insurance specific. You can do it for specific regions or something like that as well. It just depends on you, where you are and what the rules and regulations are for specific insurances, obviously. sorry. And then the other one that I had on there was actually an alert. I'm trying to get back to it, and that's going to keep going forward. The other one that I had on there was actually an alert that comes up that says when a 92250 is listed, to please make sure and list that as a, to look at your LCDs, if it's Medicare or if it's Aetna. So that way the staff automatically know to look at it, see it, and say, okay, let me come over here to my LCD. Let me make sure my primary insurance code is XYZ and not a refractive or not just cataracts or something to that effect. So that way the claim is coded correctly. So in closing, the main thing about billing rules is really think about on a higher level, how can you make a process easier and make it so to where the main things that you see every day, I always start with all of my denials and I say, okay, I'm receiving these specific denials. Is there something I can do with that? And if so, then I immediately go to my practice management system and see if I can create a billing rule, if it's insurance specific or if it's a CPT code specific. And then once I do that, if I cannot do it in the practice management system, I definitely go to my clearinghouse and say, okay, these are the rejections or denials that I'm receiving. Can you help me with these? How do I set up, how can we set up a front end edit to where I make sure that I have this information on my claim prior to it going to the insurance company? And by doing so, you should see that your denials will decrease. And the thing is that you need to make sure that you keep up with those denials or those billing rules as well, which is why I don't like putting specific diagnosis codes in there, because it could change and we not realize it until we pull a current LCD or something like that, or we get the denial. So I always try to put specifics that I can, and then if it's a broad overview, I usually do alerts. So at this time, I will open it up to any questions that may be there. Teresa?
We do not have any questions at this time. If you do have any within the next few slides, please be sure to type them in the questions and comments box, and I'll be sure to read them for Tracy to answer. At this time, we would like for you we'd like to invite you to join our November webinar, How to Stay Compliant, with Rhonda Buchholz, our Chief Compliance Officer. You can sign up now for that webinar at iCareLeaders.com. We also have other great opportunities for you to engage with at iCareLeaders. Our next one is, there we go. Back. That's okay. We're going to be in Chicago at AAO. Visit our booth to see our latest product enhancements for MyCare iMedicWare, MyCare Integrity, along with learning about our newest products of MyCare Patient Engagement, MyCare Analytics, and MyCare Payment Program. We're also offering a 90-day free trial for the MyCare Analytics. Stop by the booth to find out more about that. Also, don't miss out on the future of ophthalmic industry for the next generation of leadership with our very own Dr. Anish Kapoor. And also, Rhonda will be presenting about on how to avoid revenue loss, audit survival strategies. Be sure to stop by and check those talk tracks out. And finally, another great opportunity to engage with iCare Leaders is our 2019 User Summit in beautiful Aurora, Colorado. Take advantage of our early registration rate at only $4.99. Register today at eclsummit.com. We hope to see you there. This concludes our nope, it does not conclude our webinar. Let me double check to see if we have, I think I had some questions. Here we go. Tracy, we do have questions. Let me get back up to here. We are fairly new to IMW. How do we go about adding a specific modifier to a specific procedure code for a specific carrier?
So with iMedicWare, that is in the billing setup. And I would, for the purposes of this call, I would say let's reach out to your implementation team, and they can definitely set that up for you. If not, you can reach out to Teresa, and I will be more than happy to help you with that. It's one of those, it's within the billing setup is where that would be completed though.
Okay. What kind of billing rules do people have? I would love to have a list so we can see what things are capable of.
Okay. Let me make a note of that, and then Teresa, if I send that to you, will you be able to send it out to the attendees along with the slide deck?
Yes.
Okay.
And then we have, can we ask for help with creating edits from iCare leaders?
Absolutely. Just reach out to the support teams and the different PM systems, and they will be more than happy to work that out with you and how to set those up.
Okay. Why can't you add coverage class as an option in HCFA processing rule? As it is now, when we have to change specific information for multiple insurance plans, we need to add each insurance plan.
I'm thinking that one through. Without knowing which practice management system they are on, Teresa, can you get me the information of that?
Yes.
Of the person for that one, and I can reach out to them directly?
Absolutely.
And then we can work through that. It may be that you can't do it on the PM side, but you may be able to do it through the clearinghouse side, just depending on which clearinghouse that you use.
Okay, and the last question, how do you get to the add charge entry rule?
It will depend on which practice management system you have. iMedicWare, I know, is through the admin billing setup, and it's through the CPT code specifically. Management Plus, for example, has it in the file billing and the setup, and then it says billing rules. And then MD Office is basically the same way. So each one is different. It may be that if, as a user, depending on the user rights that were set up, you may not have access to do that, and it may be an admin user right. So if you do not have access to do that, I would definitely suggest reaching out to either your admin person in your practice or to the support teams, and they can walk you through on how to make sure and get to those.
Okay, and we'll do one more question that just came in, and if there are other questions, feel free to reach out to us and we will respond accordingly. The last one we'll ask is, for MD Office, is there a way to set up an alert for CPT 76514 to change the referring physician?
I would have to look at that specifically because everybody is different. Our practice management systems have them set up a little bit differently. So I can definitely look at that one separately. So Teresa, same thing. If you can let me know the participant on that one as well, I'll be happy to work with them individually.
Okay, great. All right, guys, we really appreciate you joining us today. I will be sending this recording out to everyone, and we will be answering individual questions separately. Thank you for joining. This concludes our webinar.